My name's Ted O'Connell. I'm the author of USMLE Step 2 Secrets. This is the first 25 of the top 100 secrets. Let's get started. Smoking is the #1 cause of preventable morbidity and mortality in the United States, and morbidities include atherosclerosis, cancer, and chronic obstructive pulmonary disease. Alcohol is the #2 cause of preventable morbidity and mortality in the United States. More than half of accidental and intentional deaths involve alcohol. Alcohol is the #1 cause of preventable mental retardation in the form of fetal alcohol syndrome. Alcohol also causes cancer and cirrhosis of the liver and is potentially fatal in withdrawal. In alcoholic hepatitis, the classic ratio of AST to ALT is greater than or equal to 2:1, although both of these liver enzymes may be elevated. Vitamins. Give folate to reproductive age women before pregnancy occurs to prevent neural tube defects. Watch for cases of pernicious anemia and treat these with vitamin B12 to prevent permanent neurologic deficits. Isoniazid causes vitamin B6 or pyridoxine deficiency. Watch for Wernicke encephalopathy in alcoholic patients and treat with thiamine to prevent Korsakoff dementia. Iron deficiency anemia is the most common cause of anemia. Think of menstrual loss in reproductive age women. However, in men and menopausal women, think of cancer, most specifically colon cancer, if no other cause of the iron deficiency anemia is obvious. Vitamin A is a known teratogen. Counsel and treat reproductive age women appropriately. That means take caution in treating acne with the vitamin A analog isotretinoin or retin A. Complications of atherosclerosis are involved in roughly 1/2 of deaths in the United States, and these complications include myocardial infarction, heart failure, stroke, and gangrene. The primary risk factors for atherosclerosis are age, sex, family history, cigarette smoking, hypertension, diabetes mellitus, high low-density or LDL cholesterol, and low HDL cholesterol. Diabetes leads to atherosclerosis and its complications: retinopathy, nephropathy, peripheral vascular disease, peripheral neuropathy, and an increased incidence of infections. Although hypertension is most often mild or moderate and clinically silent, severe hypertension can lead to acute problems known as hypertensive emergency. Symptoms include headaches, dizziness, blurry vision. Signs include papilledema, cerebral edema, altered mental status, seizures, intracerebral hemorrhage, renal failure, angina, myocardial infarction, and heart failure. In milder cases, lifestyle modifications such as diet, exercise, weight loss, and cessation of alcohol and tobacco use may be able to treat the following disorders without the use of medications: hypertension, hyperlipidemia, diabetes, gastroesophageal reflux disease, insomnia, obesity, and sleep apnea. Arterial blood gas analysis. In general, the pH tells you the primary event, whether it is acidosis or alkalosis, whereas the carbon dioxide and bicarbonate values give you the cause as they move the same direction as the pH and suggest any compensation present as they move opposite of the pH. Exogenous causes of hyponatremia include oxytocin, surgery, narcotics, inappropriate IV fluid administration, diuretics, and anti-epileptic medications. Electrocardiogram findings and electrolyte disturbances. In hyperkalemia, look for tall, tented T waves. In hypokalemia, look for a loss of T waves or T wave flattening, as well as the presence of U waves. In hypocalcemia, look for QT prolongation. In hypercalcemia, look for QT shortening. In shock, first give the patient oxygen, start an IV line, and set up monitoring in the forms of pulse oximetry, electrocardiographic monitoring, and frequent vital signs. Then give a fluid bolus, beginning with a liter of normal saline or lactated Ringer solution. If there are no signs of congestive heart failure, such as bibasilar rales, while you investigate the underlying cause. The Virchow Triad of deep venous thrombosis includes 3 elements. The first, endothelial damage, can occur in settings such as surgery or trauma. The second is venous stasis, which can occur during immobilization, surgery, or severe heart failure. And the third is a hypercoagulable state, such as malignancy, the use of birth control pills, pregnancy, the presence of a lupus anticoagulant, or the presence of certain inherited deficiencies. Therapy for congestive heart failure includes diuretics such as furosemide, angiotensin-converting enzyme inhibitors, and beta blockers for stable patients. Be sure to screen for and address underlying atherosclerosis risk factors, such as smoking and hyperlipidemia. Cor Pulmonale is right-sided heart enlargement, hypertrophy, or failure caused by primary lung disease, usually COPD. The most common cause of right-sided heart failure, however, is left-sided heart failure. In patients with atrial fibrillation, assess for an underlying cause with a TSH, electrolytes, and echocardiogram. The main management issues are ventricular rate, so if needed, slow the rate with medications. And the second is atrial clot formation and embolic disease, so consider anticoagulation with warfarin. Ventricular fibrillation and pulseless ventricular tachycardia are treated with immediate defibrillation followed by epinephrine, vasopressin, amiodarone, and lidocaine. If ventricular tachycardia with a pulse is present, treat with amiodarone and synchronized cardioversion. Obstructive versus restrictive lung disease. The FEV1 to FEV ratio is the most important parameter on the pulmonary function testing to distinguish the two, because the FEV1 may be the same in both conditions. In obstructive lung disease, the FEV1 to FEV ratio is less than normal. In restrictive disease, the FEV1 to FEV ratio is often normal. The most common type of esophageal cancer is adenocarcinoma, occurring as a result of long-standing reflux disease and the development of Barrett esophagus. Smoking and alcohol abuse contribute to the development of squamous cell carcinoma, the second most common histologic type of esophageal cancer. A biopsy must be performed on all gastric ulcers, or the ulcer must be followed to resolution to exclude underlying malignancy. Testing a nasogastric tube aspirate for blood is the best initial test to distinguish upper from lower GI bleeding, although bright red blood via mouth or anus is a fairly reliable sign of a nearby bleeding source. Irritable bowel syndrome is one of the most common causes of GI complaints. Physical examination and diagnostic studies are by definition negative. This is a diagnosis of exclusion. The classic case is a young woman with a history of chronic alternating constipation and diarrhea. Crohn disease versus ulcerative colitis. In Crohn disease, the place of origin is the distal ileum or proximal colon. In ulcerative colitis, it is the rectum. The thickness of pathology is transmural in Crohn disease and mucosa and submucosa only in ulcerative colitis. Progression is irregular in Crohn disease as it is marked by skip lesions, while in ulcerative colitis it is proximal and continuous from the rectum with no skipped areas. Location, in Crohn disease it is from mouth to anus, while in ulcerative colitis it involves only the colon and rarely extends to the ileum. Bowel habit changes. Crohn disease is marked by obstruction and abdominal pain. Ulcerative colitis is marked by bloody diarrhea. Classic lesions in Crohn disease include fistulas and abscesses, cobblestoning, and the string sign on barium X-ray. Classic lesions in ulcerative colitis include pseudopolyps, lead pipe colon on barium X-ray, and toxic megacolon. Colon cancer risk is slightly increased in Crohn disease and markedly increased in ulcerative colitis. Surgery is not indicated for Crohn disease and may actually make the condition worse. Surgery is indicated in ulcerative colitis because of the increased cancer risk, and surgery usually involves proctocolectomy with ilioanal anastomosis. That's the end of the first 25 of the top 100 secrets from USMLE Step 2 Secrets. Thank you for joining us, and we hope you will view our next video.